welcome to season 2 of MedEd Matters, Insights Innovation, your MedEd podcast. We're back and ready to go. Just to remind everyone, I'm Omar Young. I am a maternal fetal medicine physician at UNC, and I'm joined by some amazing guests today. My co-host Avi Shripad is back. Say hi to everyone, Dr. Shripad.
Hi, how's it going? Just to reintroduce myself, I'm also a urogynecologist at UNC and thrilled to be back for season two.
How was your summer, Dr. Shripad?
Good, good. Just we had our annual OGS conference out in Vancouver, so that was a nice little trip a couple of weeks ago, and good to be back. Good to be back in North Carolina.
Awesome. Well, in season 1, we wanted to create a podcast that anchored folks in what is medical education, re-inspiring you all to really take on the task of being involved in academic medicine, advancing the mission of clinical education, research, and innovation in clinical care. And in season 2, we're going to take a little bit of a different take with, trying to integrate medical education into what is going on in the world around us because we don't operate in a vacuum. And so, our first episode in this series is going to be focused on health equity in 21st century medical education. And I have two amazing guests with us today. They are Dr. Jenna Richards and Dr. Antoinette Danvers. And I'll let Dr. Richards introduce herself.
I'm Jana Richards. I am a board certified physician with over 20 years of experience in obstetrics and gynecology. I'm currently an assistant professor in the Department of Obstetrics and Gynecology at the University of Chicago. I'm also the associate program director in our department for our residency program.
Thank you, Dr. Richards. Dr. Danvers?
Hi, hello everyone. I'm Antoinette Danvers. I am a complex family planning specialist at Montefiore Einstein. I'm an associate professor in the Department of OBGYN, and I'm also the residency program director.
Awesome. Thank you, Dr. Danvers. So we got a lot of folks here in the world of OBGYN representing multiple facets. And what I wanted for us to discuss today is a really hot topic that's going on around the country right now is thinking about health equity in terms of maternal morbidity and mortality or provision of and access to care. We always talk about the social determinants of health. What does that mean? So I guess I wanted to start this conversation by exactly clarifying for our viewers and our listeners, what exactly, Dr. Danvers, does health equity mean to you?
Yeah, thank you for that important question. As a program director, I'm always trying to uh, link the way I think about clinical care and training. So my answers really really tries to gel both ideas. So in terms of the patient care perspective, for me, health equity is about creating conditions where everyone both the patient and the learner has a chance to thrive. In medicine, I think about it in terms of outcomes, who has access to care, whose pain do we believe, whose health is we're able to improve, what are the barriers we're encountering. In terms of my role as an educator, I think about how health equity shows up in the learning environment, in the hospital, who gets the exposures that they need for their development, who has the mentors, who gets the doors opened, who make mistakes, and it's viewed as opportunity for growth versus a shortcoming. So all of those things I think around about in terms of health equity, because I really see our learners as these vectors for improving health outcomes for all our patients. So it's hard for me to separate the two concepts.
Yeah. Dr. Richards?
Let me just start by saying I believe health equity is a fundamental human right for all individuals. It's something that all people are worthy of simply because of their existence and presence on earth. Health equity is achieved when everyone has an opportunity to engineer their best possible health, regardless of their insurance or socioeconomic status, color of their skin, ethnicity, sexual orientation, gender, or formal educational level. I think this becomes even more important in the practice of OBGYN because we're talking about making sure that all people have health equity from the womb to the tomb. The Maasai people of Kenya have a greeting in the language of Swahili, Kasirian Injera. They believe they share this greeting when they see each other or meet new people in the community. It means, and how are the children? The reply is, the children are well. They understand that peace and safety prevail if we prioritize the young, the vulnerable, and the powerless in any society. And societies flourish when children are the indicator of how well a society is thriving. Healthy pregnant people not only contribute to the welfare of their families, but to the overall well-being and prosperity of this country. And with this understanding, how do we find ways to achieve our purpose as medical educators and really integrate health equity into every curriculum?
I love that. I love that. It really captures exactly why I went into medical education. Um, you know, we always talk about like education is always on the low end of the totem pole. It's always the forgotten thing. But without medical education, you're not going to be able to take care of patients and you're not going to be able to do that research that you want to do. So I really do think it is the anchor and the foundation of everything that we do on a daily basis. Um, so thank you for that.
Yeah,
Dr.
and I'd like to echo that as well. I mean, I think both of those quick perspectives really encapsulates everything that we do from patient care to um, a clinical learning environment. And so what I'd like to do is just kind of focus on that second piece in terms of both of your roles as educators and program leaders. What does health equity mean, maybe more granularly in the context of a clinical learning environment?
I mentioned before, health equity, when I think about the learners and health equity, I think about who and what do we need to do to make sure we're teaching, that people are learning, um, in a way that will carry the importance of health equity forward. So their approach to each individual patient, looking at each individual patient, trying to deliver the best care possible. That is their right, right? So that's like one framing and like the learner to the patient and what we're teaching. And then the next framing for me is what about the environment in which the learner is working in? And is that a safe place for them to feel that they can deliver that care and bring that forward? And so, what are, thinking about how we're assessing the learners, how we're teaching them, who's in the room, all the educators who are participating in that experience, and then all the members of the healthcare team that are all really participating in the experience that each learner has ultimately impacts them and whether they want to continue to work in an environment where they want to carry this work forward. So, I think about my role as a residency educator and making sure that all those pieces are aligned around that shared mission and goal.
I love
Yeah, I
it.
think that's an excellent point in the sense of, there's value to everyone inherently being there, but there's also value in the role that they can provide within the context of a team. And those things tend to go hand in hand with an environment of respect and safety. So thank you, Dr. Danvers. So, Dr. Richards, anything you'd like to add kind of to the clinical learning environment piece?
I kind of want to also back up a little bit. And when we think of the clinical learning environment in medical education, I think we also need to think of the environments where they actually were educated prior to medical school or prior to coming into medicine. And how do we think about how we can improve those environments as well to certainly help them or increase numbers of them, certainly making it to the point of getting into medical school? And how do we create environments that may be similar to environments that they came from? and really thinking about how we improve the pipelines if we really want to increase the numbers of minoritized people in education, but also if we want to move the whole field of medical education forward. Because I truly believe that inclusivity is certainly a major benefit for all practicing physicians and certainly a major benefit for medical education.
Yeah, there's great data to show that when you have an inclusive team, an inclusive environment, you actually have improved outcomes. And so I think that's one of the whole points of why we are having this conversation. And so, equity in medical education is central to improving the outcomes, not just for our patients, but also for our trainees. And despite increased awareness and structural inequities, bias, and assessments like Dr. Danvers was talking about, and a lack of inclusive environments persist. And so this episode of this podcast is going to try to amplify the voices of medical educators like you all in order to help improve our clinical learning environments, make sure that they're equity based, and to cultivate really psychologically safe spaces. So I think that now that we framed exactly what health equity means, let's talk about what gets in the way of making those environments inequitable. Um, so, Dr. Richards, would you say are the biggest barriers to creating clinical learning environments that are equitable, either structural, cultural, interpersonal, what have you?
I think the biggest barriers are getting people to understand that health inequities are not fixed, they are not inevitable. They're the result of systemic injustices that can be eliminated and overcome. And we all know that education is the great equalizer in all of this.
Yeah, I think that's really important. When someone doesn't have the foundation, they're not going to be able to do what they're either expected to do or what they desire to do. Dr. Danvers?
Thank you. I think I want to piggyback off something Dr. Richards mentioned earlier about the environments before coming into med school. Because one of the barriers I see is how much our system rewards a certain type of a learner. Like who has all the tools coming in from day one. And from my perspective, our trainees are coming from such diverse experiences, like their life experiences, not just, their racial background, but their experience in general creates different types of preparation before coming in the door. And we know good clinicians, it's not just about what you know, but it's how you are organized, how you're able to communicate with uh, your diverse team members, your ability to manage competing priorities, sort of the difference in the pressure that gets ramped up when you become a resident. And not everyone arrives fully formed. And I think we don't always look at it as a reflection of um, effort or, and potential. Um, I reflected a little bit about this when I was thinking about my role as a parent. I have a teenage son who went to a private K through 12 in New York City. And I was shocked by the opportunity because I was a public school graduate, and they were teaching these kindergarten kids how to use a planner. Like in the kindergarten, he had a planner, managing his time, writing down his homework, and like ingrained from a very early age, time management and these skills that you're going to need later. And I didn't learn those skills so much later, like through trial and error in college and med school, and finally as a resident, you just sort of figure it out. But I wasn't going to walk in the door just ready with all these tools. And so a lot of what we're calling readiness is like forming years before our trainees ever reach us. And I think our challenge in our learning environment is that when we see someone who hasn't had all this early exposure, how do we judge them when they enter training? And how are we set up to support their growth? sort of as a equalizer. How do we get everyone on the same playing field? And, because once there's a narrative of like a struggling learner and it starts to take hold, it often grows and can be sort of this repeated cycle. So for me, creating equity in my learning environment and overcoming those barriers like has forced me to think about how I've thought about readiness, and how we're going to peer feedback and coaching so that we're giving learners the how and not just like the what you need to do to be a good trainee and to be a good clinician and deliver equitable care.
I wish I had your son's education in
Yeah,
making
I mean, it would have saved so much struggle, right? But it's real, right? Everyone's coming in with different levels of preparation in a very tough environment, and we're trying to get everyone to succeed, and that should be our goal. And so, you can see where bias and our perceptions can be challenged in some of those contexts.
So you bring up the concept of, the hidden curriculum, right? In terms of there are things that you need to know and need to do in order to succeed that are not explicitly taught. And then we would think about that in the context of health equity. I think of this, this graphic where everyone is trying to look over the fence, but
Mhm.
some people are tall, some people are short, some people may not have a box to stand on.
Mhm.
So it's important that we understand the difference between equality, which is giving everyone the same thing, and equity, which is allowing people to get what they need to succeed in order to get to the point where you want them to be. And I think that's really important for all of our listeners and our viewers to really emphasize when it comes to being in medical education. Um, Dr. Richards, do you have something that you wanted to say?
I was just going to say, sort of to piggyback off of what you said, in order to give people what they need, it means you have to really pay attention when you're interviewing, when you are looking for the talent, when you are accepting your residents. You have to understand that what their needs are, but you also have to make sure that when they come to your residency program, you have those things in place to help them succeed. You're
Mhm.
not just giving everybody the same size shoe, even though everybody doesn't have the same foot. But it means that you have to be intentional and you really have to think about how you're going to assemble this team and how you're going to support the team once a team gets there.
Yeah.
Exactly, exactly. Dr.
Yeah.
Shah, can you tell us about if you've had any experiences in any clinical environments and that were, not necessarily equitable, or how did that work out and what happened?
Yeah, I think that's one of the things that Dr. Danvers brought up really struck a chord with me in terms of learning opportunities that are iterative based on, partially maybe prior performance, but I think there is quite a bit of literature to demonstrate that this power of narrative around a resident or a medical student's performance is a little bit of a self-fulfilling prophecy. So, in my world, we have a lot of learners at different levels trying to master different parts of surgical care of, patients. And so I think what I have really kind of seen, and, I can think of specific examples, but more generally is the power of this narrative of, maybe this resident or medical student or learner isn't quite up to task. And then subsequently, they get less opportunity to improve and to prove themselves or to prove their competency and prove their progress. And all of a sudden, you have different learners playing different games, right? In the sense of one learner gets so many more opportunities, grows, learns, improves, and the other maybe comes from a different starting point, but doesn't have the same opportunities to do that. I think one thing that I've really appreciated in my current work environment is when we do feedback with learners of different levels, there is a spectrum of folks that are in the room for those conversations, meaning from potentially residents to fellows to attendings and mid-level providers. So we do get a lot of perspectives as to how this learner may have come into our rotation or a learning environment, and subsequently, how they've used their opportunity, and how we can better assist them um, to sort of do the best that they can and to make it as equitable as possible in terms of their learning environment. So thanks for bringing that up, Dr. Danvers. That definitely was something that, I've been thinking about. And maybe I'll kind of pivot it to you guys to talk about different examples that you may have noticed in terms of, past or present moments of exclusion, or, general kind of ideas where you've seen the health inequity come out in either learning environments or otherwise.
I think one of the ways, it's kind of subtle, but I certainly have had this experience. In our department, when you come on the department, they have these larger than life, huge pictures of all the past chairs. They've all been men, no females, no Black chairs. And even when you look at the next picture, which shows the whole section, there are very few section chiefs, certainly very few full professors of people of color. And this can easily make one feel alienated, unworthy, uncomfortable, kind of feel like they're not an add value player on a team. And it might make them actually question if their work is just performative or are they really adding value.
Mm.
And I think it's important to recognize this, how really small, subtle things can make a really big difference. And if we really want to change the narrative, we have to help all of the faculty recognize that their work is not just performative and they really are an add value player on the team. And in fact, everyone's presence is important because we know that when everyone is in diverse rooms, this really makes a difference and improves the outcome for all of the faculty and staff.
Mhm. Um, I've worked in a number of different type of environments. I think where we are in the Bronx, I think a lot of us come into working in what's clearly an underserved environment and come in with a desire to um, improve health outcomes of, people who are experience like levels of really high social need. And so it's like we feel like we're aligned in that. Um, and so I think it makes it even more subtle. But having worked in different environments, I've been in the South, I've been in high resource academic centers, I've worked in a community hospital, and then coming back into this sort of a more um, underserved population where most of our patients are publicly insured. Sometimes what looks like like high level of care, everyone's doing the best they can, but you know that it looks different because I know what it looks like in another environment. Um, and so sort of there's this subtlety in, you know, are we really, is this health equity? Because we know that there's more we can do, but compared to everything else we're doing here across the board, everyone's getting the same care. And so, you know, we're exposed to this idea that everyone's getting the same level of care, so it's equitable. But unless you are experiencing like other environments where you can see the bar is much higher, it's not always clear. And I really try to make sure that like that's being taught, and at least like as an intentional framing around, you know, there is still more, we can do. But yes, right now we're doing the best we can, but that is not necessarily the bar. But that comes with sort of this experience of seeing, what it all looks like for everyone else.
Yeah, when I think of inequities in the clinical learning environment, I think of specifically, you know, tr trying to provide students with some like learning disabilities accommodations, realizing that, not everyone also doesn't learn in the same way. And so you may be trying to teach material, but the way that you're teaching the material actually might not be effective for that specific learner. Um, Other instances in which I see inequities in the clinical learning environment is a lack of representation on units, be that on the gynecology floor or in the emergency room or on labor and delivery, where learners come into these environments and, like Dr. Richards was saying, feel isolated or there is a sense of otherness, whether that be from whatever demography you would want to speak from. I speak from this personally as when I was a resident, um, I had those moments of isolation and othering, and definitely it contributes to how you perform psychologically and your own sense of self. And so we really need to be cognizant of how the exteriors of our clinical spaces are going to really contribute to the psyche of our learners. And,
Mhm,
a little instances here and there or explicit things that can create inequities may derail someone's career.
mhm,
For instance, like, I've had folks in the past that have said, hey, I wanted to go into, a certain specialty, but once I got there and saw how people were acting or behaving, then I was like, I can't do that for my life. And that really is that really is quite terrible, to be honest.
Mhm.
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 Can I add to that,
Yeah.
Dr. Young, in that not just what folks look like, but how comfortable people feel in speaking up and asking questions and advocating for what they want. That is one of the differences that I see from where I sit. And some of that also comes from, being able to do that way for many years before ever entering residency. That confidence that you come in with, you know, feeling that you have a right to be heard and seen and taught gives you the confidence to ask for what you need. You get invited to the table. There's just differential opportunities that come up for you as a learner. So, who gets to go to the cases when it's super busy, so you can see where this also comes out on the other end with like differential case numbers even, right?
Mhm.
When you go to the OR, who's actually operating and getting enough opportunity that they're logging it,
Mhm.
right?
Great. Well, this has been a very, very comprehensive conversation, I think, about a lot of different levels that can contribute to health inequity in patient care and in the learning environment. I'd like to, shift gears a little bit right now for the next part of our conversation about maybe some actionable solutions. So we've sort of started to mention a couple of these pain points that we've noticed throughout, a learner's progress, whether it's before entering medical school, during residency. We have a great sort of expertise here on residency education and leadership. So I'd just like to start by posing the broad question: what are some strategies that you've seen that have made a real difference, or that you're currently thinking about trying to implement or implementing? And maybe we can start with you, Dr. Richards, as to some solutions or ideas for the solutions moving forward for the number of things we've talked about.
So I think one of the major structural strategies or changes that we as a whole country have talked about and have studied is really addressing health inequities in terms of building a physician workforce that's more representative of US population. In terms of key players in medical education, I think we really have to pay attention and continue to fight for taking diversity seriously. And we know the benefits of diversifying the physician workforce is going to be key in addressing health inequities. We have studies that certainly show that minority physicians play a key role in providing access to medical care where it certainly is needed the most. We have data to support that non-white physicians care for a large proportion of the underserved and sicker patients. Therefore, just starting with increasing and really continuing to fight for racial and ethnic diversity of the physician workforce is going to be key. Now, we can't start with this at the level of medical school. This is something we have to, like I said before, think about how do we even change the educational system we have in this country? How do we even get more the representation in schools and teachers to be more representative of the population in this country? When they start pre-K, it's not just about what happens once they get to medical school. And in order to do this, we know we have to change the mindset of many people who hold leadership positions in medical education. We have to learn how to lead with inclusivity. And we have to listen and teach those in leadership positions the benefits of creating better policies aimed at recruitment, retention, and the promotion of racial and ethnic minorities. We have to show them that inclusion changes the conversation, which will then lead to certainly changing our outcomes. We also have to change the way that we educate doctors. And we have to make sure that medical students see their education as not only a way for healed people, but to also transform systems that have systemically, historically oppressed people. And I think that really should be the desired outcome of a holistic medical education.
Yeah.
So where does mentorship and sponsorship fall into this? I feel like Dr. Danvers, when Dr. Richards was talking about changing the system and starting it, very early on,
Mhm.
we need folks, you need to have role models to
Mhm.
do that change, right? So I guess looking at that from the perspective where we are anchored in terms of with medical students and residents, fellows,
Okay.
what does mentorship and sponsorship mean to you in terms of your own career as well as for your trainees?
Um, so, you know, for me, the structured mentorship, we need like a structured mentorship to overcome some of the barriers that like we already discussed. I'll say from the residency side this year, one of the things that I tried to implement is so I started to do this coaching transition coming into residency, just like reflecting back on like gaps and trying to have people feel more prepared. Setting up a plan from very early on where we are meeting with our interns and offering some coaching and transitioning from med school. Um, it's sort of some mentorship, but it's more direct in sort of looking at now that you're here, where are we struggling? Where do we have some opportunities that we can start to work on and like providing some tangible tools that they can take with them and build it into their day to day. That piece where you're like the hidden curriculum that no one taught you, I'm using mentorship to sort of teach that in a more one-on-one basis at the start before the sort of perceptions and that cycle of feeling lost sort of set in. Sponsorship and mentorship are also key in like creating opportunities for their future, right? So, we know that a lot of the additional opportunities that they're presented with in their training affects what, opportunities they have after they leave training and the kind of work that they'll do after they leave training. And so, you know, when when opportunities are presented to me as a program director, sort of making sure that like everyone's sort of getting an opportunity and not just those who are able to speak up. Um, and so that's where I think we can be really deliberate and intentional about setting up opportunities and giving people a chance to thrive.
I think that's great, and I love that program that you've started at your
Starting.
institution or starting. It's
Yeah.
sort of creating this
Yes.
individualized learning plan. That's a great way to frame the start and the transition of resident or medical school to residency. Um, I'm curious in terms of sort of how the back end of that looks with evaluation and feedback culture, how that looks and certain areas of maybe solutions that you've tried or problems you've identified. And maybe we can start with Dr. Young since, I know you have a particular interest in feedback and, maybe commenting on that.
Yeah. Feedback is a beast. Everyone hates it. Everyone wants it. But it's so hard to give and to receive. Um, I think, you know, we really need to do a better job at the beginning of training in teaching our trainees how to receive feedback. Me telling you constructively that you didn't do this great job at this surgery, this procedure, this patient encounter is not a personal attack on your character. And I think that's what we need to clarify for specifically this generation of learners. The flip side is when we're starting in faculty positions, we need to really learn exactly how to give that feedback. Many of us have been in situations where we were essentially attacked and impugned and, basically told that you're terrible, horrible. Um, that's not how to communicate effectively, right? If you want someone to really have a substantive, meaningful experience with you, you can't really instill fear. There's really good neurocognitive data to show that when you really create an environment of fear, you stop learning. All that cortisol stops you from laying down those pathways. And so if we really create environments in which we've emphasized psychological safety, and I'm able to effectively communicate to you as the trainee, and you are able to effectively respond to that information, then we've both had a substantive experience. And so I think it really behooves folks involved in faculty development and professional development and residency directors, things like that, to really create this feedback culture where it is a 360 thing, of which you give and receive that feedback. Um, that's the only way that we're going to promote environments of fairness and wellness. Otherwise, it's just not going to succeed.
Well said. Any other kind of additions, Dr. Richards or Dr. Danvers?
I
I
will,
totally agree
yeah.
with all of the things that Dr. Young just said about feedback. I think another important part of feedback, and it kind of gets back to what Dr. Danvers said, is how important it is for you to actually know your residents when you're giving them feedback. If you know that they went to a school where they learned how to use a planner in kindergarten, then your feedback may be a little different from someone who didn't get to figure that stuff out until they went to college. So I just think a big part of feedback, mentorship, medical education has to be, do you even know your residents? Do you even know the people that you're teaching? Do you know them outside of the objective data, which we have, which is testing, the feedback forms we certainly use when we see them in the operating room, performing certain procedures. But do you know things besides that about them when you are giving them feedback?
I, I think having tried to do like faculty development around feedback every summer for the 3 years I've been in this role, I realized another barrier recently, and that was assessing what the problem is in the first place. And we don't always have the tools to identify what it is that the learner is struggling with to be able to give them feedback and then suggestions for how to improve. Um, so for example, I will say I would get very like emails, even like informal feedback, or meet with someone and they say, oh, like this resident, I think they have to work on their medical knowledge. Well, I know objectively their medical knowledge is fine, but you know, but what I think they mean is like there's some clinical reasoning and judgment issues that sort of needs a different response from if it's medical knowledge, right? So like even diagnosing the problem may look different, or the presentations, or their presentation is disorganized, or they're not able to prioritize their task. They're always, behind. And it may be that they don't know how to do task prioritization. So I found that there is some development work that needs to be done in helping faculty recognize what they're seeing and what it is in order to be able to give feedback and like how to improve that. So I'm sort of trying to shift my gears around like how do I approach feedback development next time. And I think it's starting with, well, here's how people learn. Here's how people learn in medicine, and then, here's how we're gonna be able to assess and find out when there is a problem or not. And then I'll get into the feedback session. It's sort of how I'm like sort of building things because it's just been like I've found myself adopting like the role of making the diagnosis. Just give me all your things and let me figure out the diagnosis, and then I'll give this like feedback.
Well, we've really like started to really scrape the surface on solutions to this. I would say it's a ridiculously large problem that only today's conversation is scraping the surface, and we recognize that, but we also recognize that if we don't have these conversations, then nothing will change. Um, and so one of the things that we like to do at the end of our podcast is to leave our viewers and our listeners with something called a med moment. And that is that one little nugget that you would want the listeners and the viewers to take away. So, Dr. Richards, what is your med moment?
If we really want to think about how we're going to create equitable learning environments, we have to understand that we all have to take accountability and actively find ways to bring health equity to all individuals in our society. And words like diversity, equity, and inclusion are not bad words. And if we are not going to use these words, then let's think about what the antonyms of diversity, equity, and inclusion are: sameness, unfairness, and exclusion.
Dr. Danvers, what is your med moment?
Um, that every trainee deserves to have a training experience where they are able to thrive. And that is through well-formed feedback and being given the tools that they need to, catch up if they need that. And so, really trying to think universally about how we build programs that are excellent and equitable for everyone.
Dr. Shripad?
I'll come at this from a bit of a more in the busy clinic moment where you're dealing, with the new learner. And one of the key takeaways that I've kind of gleaned from this conversation is the holistic nature of where this starts, which is very early, and where you're meeting a trainee, which is much later in their story. So, probably Monday or Tuesday when I work with somebody in the office or the OR, my question to myself is going to be sort of where they've been and where they're going. And as educators, I think being able to more efficiently understand both of those questions as to what is this learner's experience, both very tangibly in terms of medical education, surgical education, but also all the things we've talked about their experience and their road to get to the learning experience that they're in with you right now, and being able to efficiently and compassionately kind of synthesize those things into a moment of education that's really 360 degrees, like you said, Dr. Young, as to the benefit both for the learners, but also, why we do what we do, which is, incredible fulfillment to help them through this time of their education.
I love this. I just wanted to thank all of our guests today, Dr. Richards, Dr. Danvers, my co-host, Dr. Shripad. We've had an interesting and substantive and really thought-provoking conversation today. As we go through our series on health equity, we have a couple other episodes in this series coming up. Our next episode is going to be about teaching advocacy. So really stay tuned for that. And I think that Dr. Shripad wants to talk to me about what holistic review means. And so we'll have a conversation about that. Later this year, we're going to be talking to you about technical skills and surgical training and innovation in curriculum design, as well as talking to our advanced practice providers about teaching in the ambulatory setting and exactly how can you be a better educator when you're having a crazy clinic. I want to thank all of my guests and our viewers and our listeners, and we'll see you next time on MedEd Matters.